So, Dr. Ritu, you're ready with your presentation, isn't it? I will just get it started. So, good evening, all. Welcome to this episode of Journal Club. And today we are going to discuss two important papers which challenge the concept that more is better. It challenges that concept. So, and both have to deal with fluid resuscitation. And we are moving more towards personalized and individualized approaches. And here we have with us an August assembly, and I welcome each of them. We have Professor Rakesh Garg. Good evening, sir.
Namaste, ma'am.
Um, sir is a well-known figure and hardly needs any introduction. And sir is a astute academic and editor-in-chief for IGA. Welcome, sir, and thank you for being here.
Thank you.
And we have our mentors, Dr. Prashant from D.Y. Patil Medical College, and Dr. Anjana, senior consultant from Manipal Hospital, Bangalore. And we have JP, a well-known dynamic academic, and we also have our well-known academics, Dr. Tanmay. Thank you for being here. We have our students, Dr. Ritu Varki, who will be presenting the first case, the Andromeda Shock 2 trial. She's a first-year resident doing her DM critical care from D.Y. Patil Medical College Super Specialty Hospital and Research Center. And for the next paper, we have here Dr. Marina, who is doing her DRNB critical care. She's in her third year. She's also from Manipal Hospital, Bangalore. And over to Professor Rakesh Garg. Sir, you can say a few words and set the club in motion.
Thank you so much, madam, and welcome back to the ISCCM Journal Club. So the basic purpose of Journal Club is not only to understand the well-researched published paper, which gives new insight for our understanding, but simultaneously at a part of Journal Club, we also need to understand that whether the outcome or the method section, which has been included into that published paper, we do have two interesting papers, but then we need to understand whether the methods of the said study and the outcomes are applicable to our patient. So this will be a critical appraisal of the published paper, and it has many nitty-gritties to attach to it. So we need to understand whether we can pick up the outcomes, the results, which has been published into this landmark trial, two trials that we'll be discussing today, whether we can take it into a clinical practice. So all the audiences which are listening to us, that's one message I just want to give, that all papers which are published across the world, though they are good papers, well-researched papers, but they may not be applicable to my population. My population means anybody who is listening to us, because their patient profile may be a little different, their patient subset of population may be different. So that is what the critical appraisal is, and that's the basic purpose of Indian Society of Critical Care Medicine, to start the Journal Club, not just to read the conclusion of a published paper, but also to critically appraise. And thank you so much, each one of you, for joining us and taking it forward. Thank you so much, and over to you, ma'am.
Over to Dr. Ritu Varki and our mentor for the first paper, Dr. Prashant. Over to you.
Good evening, everyone. So I request Dr. Ritu to start today's Journal Club with Andromeda Shock 2 trial. Over to you, Dr. Ritu.
Okay, thank you, sir. Good evening, everyone. Myself, Ritu Varki, first ADM President, Critical Care Medicine at Dr. D.Y. Patil Hospital, Pune. First of all, I would like to thank you, everyone, for taking your time, for having been here today. And I'm really grateful for this opportunity. I would also like to thank my mentors, Prachi ma'am and Prashant sir, for the invaluable guidance and constant support throughout. So today we will be discussing one of the most recent, highly influential landmark trials in the management of septic shock, Andromeda Shock 2 trial, which evaluate the personalized hemodynamic resuscitation targeting capillary refill time in early septic shock. Andromeda Shock 2 trial. This is a large, multi-centered, randomized clinical trial conducted across 86 intensive care units in 19 countries. The study was published in JAMA in October 29, 2025. And the picture shows some of the principal investigators, including Professor Glenn Hernandez and Gustavo. So coming to introduction, septic shock continues to be a leading cause of mortality in critically ill patients worldwide. Early hemodynamic resuscitation is a cornerstone in the management. And however, optimal strategy for hemodynamic resuscitation with IV fluids, vasoactive agents remains uncertain till now. And various pathogenic factors, including vasoplegia, cardiac dysfunction, hypovolemia, are included and overlap in the septic shock pathology. And this heterogeneity of septic shock limit the effectiveness of one-size-fits-all resuscitation strategies. Septic shock resuscitation aims at optimizing the hemodynamics with improved tissue perfusion and reverse cell metabolic rearrangements. Capillary refill time is a simple, non-invasive bedside marker of tissue perfusion, with improvement often reflects successful resuscitation. Coming to rationale of the study, the current septic shock standard care follows a one-size-fits-all model for the IV fluid resuscitation, targeting a map of more than 65 millimeters of mercury and initial fluid resuscitation of 30 ml per kg for all the patients. Here, the heterogeneity of the septic shock is not considered, leading to unnecessary fluid administration and pulmonary edema. In SHOCK 2 trial, consider the capillary refill time as a primary physiological target, simple, rapid, non-invasive bedside marker, which has been increasingly recognized as a surrogate of peripheral perfusion compared to traditional metrics. It also includes a personalized hemodynamic resuscitation algorithm, normalizing the capillary refill time, sequentially assessing the fluid responsiveness, vasoplegia, and cardiac dysfunction, thereby addressing the heterogeneity of the septic shock. The investigators also sought to prove the superiority of tailored, phenotype-guided care over standard care in improving resuscitation. Coming to research question, does a personalized hemodynamic resuscitation strategy aimed at normalizing the capillary refill time improve outcomes in early septic shock compared to usual care? And the objective of the study, to determine the effect of a personalized hemodynamic resuscitation protocol, targeting the capillary refill time on a hierarchical composite outcome of mortality, duration of vital support, and the length of the hospital stay. Design is a randomized clinical trial conducted across 86 ICUs in 19 countries from America, Europe, and Asia. The duration is from March 2022 to April 2025. Inclusion criteria include patients above or equal to 18 years old recruited up to 4 hours of septic shock onset, and the exclusion criteria: pregnancy, more than 4 hours since septic shock, active bleeding, concomitant severe ARDS, active hematological malignancy, and patients in whom the capillary refill time cannot be accurately assessed. Coming to a randomization, a total of 4,553 patients were assessed for eligibility initially, and 3,052 patients were excluded because of various reasons, like they were not meeting the inclusion criteria and some refused to sign the consent. So ultimately, 1,501 patients were randomized into 2 groups, into the intervention group, CRT-PHR group, and the usual care group. The intervention group underwent treatment, or they underwent a personalized hemodynamic resuscitation protocol targeting the normalization of capillary refill time. Whereas the usual care group, they underwent treatment according to the standard surviving sepsis guidelines protocol. So 744 patients were randomized to the intervention group, and considering all the dropouts, finally 720 patients were included in the primary outcome analysis in the intervention group, and 747 patients were included in the primary outcome analysis in the usual care group. So the patients randomized to the intervention group, they underwent a sequential multi-layered personalized hemodynamic resuscitation protocol for a study duration of 6 hours, targeting normalization of capillary refilling time. The patients with a baseline normal capillary refill time, they did not undergo further intervention. Periodic monitoring was done with hourly monitoring of capillary refill time in those patients. Whereas the patients with abnormal capillary refill time, they underwent interventions in 2 progressive tiers. In the tier 1, it started with the pulse pressure. So the patients with pulse pressure less than 40 millimeters of mercury, that indicates hypovolemia and low stroke volume. For them, fluid responsiveness is assessed. If they are fluid responsive, we'll give a fluid challenge 500 ml of crystalloid over 30 minutes and we'll reassess the capillary refill time. If it is still abnormal, we can give one more 500 ml crystalloid over 30 minutes. That is a maximum of 1000 ml can be given and we'll reassess the capillary refill time. So in those patients with pulse pressure more than 40 millimeters of mercury, we'll assess the diastolic blood pressure. If it is less than 50 millimeters of mercury, that indicates reduced vascular tone or vasoplegia. For them, a diastolic blood pressure push is given. That is given by increasing the dose of norepinephrine and keeping the diastolic blood pressure more than 50 millimeters of mercury, and we will reassess the capillary refill time. If both these interventions fail to normalize the capillary refill time, we will go to tier 2. It starts with a basic echocardiography, and we look for LV or RV dysfunction. If it is present, we will go for specific treatment. And if it is absent, and if the patient, if it is absent, we will see for fluid responsiveness of the patient. If the patient is fluid responsive, we will give further fluid challenges till the safety limit is attained. And if the patient is not fluid responsive and with a history of chronic hypertension, mean arterial pressure test is given. That is, we increase the mean arterial pressure to 80 to 85 millimeters of mercury temporarily for 1 hour by increasing the dose of epinephrine. And we'll reassess the capillary refill time. If it is normal, the capillary refill time appears normal, then we will continue the mean arterial pressure of 80 to 85 for further 6 hours of the study. If it is still abnormal, then we will go for the dobutamine test. That is, we'll give a fixed dose of dobutamine, 5 microgram per kg per minute for 1 hour, and we will reassess the capillary refill time. If all these interventions fail to normalize the capillary refill time, we'll go for rescue therapies like high volume filtration, extracorporeal absorption, etc. So this flowchart again emphasizes the pillars of the protocol. That is the pulse pressure indicating stroke volume, hypovolemia, the diastolic pressure indicating vasoplegia part, fluid responsiveness, cardiac dysfunction, and the ionodilator test. So we can see all the pathogenic mechanisms included in the septic shock is covered in the protocol. Coming to the comparison group, the usual care group, they underwent treatment according to standard surviving sepsis guidelines. That is target of MAP more than 65 millimeters of mercury, use of norepinephrine as a first vasopressor, and crystalloids as the fluid of choice. And the capillary refill time is measured at 0 hour and 6 hours in these patients. So another important question, how do you assess the capillary refill time? We will apply a firm pressure to the ventral surface of the distal phalanx of a finger using a glass microscope slide. And the pressure is sustained until the skin appears blank, and it is maintained for 6 seconds and then released. And the time required to return to normal skin color was measured with a chronometer. And the capillary refill time more than 3 seconds is considered to be abnormal. Coming to outcome of the study, primary outcome include the measurement of hierarchical composite of 28-day mortality, duration of vital support, and length of hospital stay. Secondary outcomes include all-cause mortality, vital support 3 days, and the length of hospital stay within 28 days. Statistical analysis, 1,501 patients were enrolled, and the power of trial is 88%, which shows superiority in the hierarchical composite outcome. And the primary outcome is analyzed using stratified win ratio method. Secondary outcomes were analyzed with the gatekeeper procedure with the type 1 error at 0.05. So what do you mean by this hierarchical composite outcome? It is a measure of combined outcomes in a hierarchical manner. That is, in spite of focusing on a single clinical endpoint, here we consider multiple combined outcomes which will contribute to the benefit of the patient or benefit of the study. And what is this win ratio? It is a statistical analysis method used to measure the hierarchical composite outcome. So what we do is, here we have two groups, intervention group and a control group. All the patients in the intervention group is compared and paired with all patients in the control group and following a hierarchical pattern. So in our study, the first primary outcome, the hierarchical order comes mortality. So in the intervention group, if one patient survive, that is a win for the intervention group. And if one patient expire, it will be a loss. And if both patients survive in both the groups, it will be a tie. In case of tie, we will move to the secondary outcome. That is the duration of vital support in our study. So less number of days in the vital support, intervention group, it will be a win. And more days, it will be a loss. And same days, it will be a tie. If it's a tie, again, we will go for the third outcome, that is the length of duration of hospital stay. So less number of days in the hospital, it will be a win to the intervention group, more days loss, and the same days would be a tie. And all the number of wins will be calculated. And finally, we will calculate the win ratio, that is number of wins in the intervention group by number of wins in the control group. If the ratio is more than 1, it indicates intervention group is superior to the control group. Coming to the results, patient characteristics. Patients in both the groups had similar clinical and demographic characteristics at baseline. The mean age is 66 years with 43.3% of females, and the most common source of infection is intra-abdominal sepsis. Protocol interventions. CRT-PHR group exhibit a greater degree of normalization of CRT of 85.9% compared to 61.7% in the usual group. And the CRT-PHR group received less fluid, lower central venous pressures, and lower lactate levels. Primary outcome, hierarchical composite of mortality, duration of vital support, hospital length of stay. There is 1,31,131 wins in the CRT-PHR group compared to 1,12,787 in the usual group. And the stratified win ratio is 1.16 with a 95% confidence interval and p-value 0.04. Of the three components of the win ratio, the duration of vital support yielded the highest number of wins. Coming to the secondary outcome, the CRT-PHR group had a higher number of mean organ support free days and faster decrease in SOFA score. No significant difference in 28-day mortality or duration of hospital stay is found. Coming to discussion, CRT-PHR was superior to usual care on a hierarchical composite outcome of mortality, duration of vital support of length of hospital stay at day 28, and the results mainly driven by shorter duration of vital support, higher rate of CRT normalization with less fluids, inotropes, and effective tissue perfusion is seen in CRT-PHR group. And the CRT-PHR decreased the odds of over-resuscitation and subsequent organ support requirements, leading to efficient recovery of the patients. And the hierarchical composite outcome and win ratio is a superior and greater statistical power. Coming to the strength of the study, it is a large multicenter, multinational randomized control trial with high external validity and generalizability. And the large sample size improves the statistical power of the study. And the novelty of the intervention is the personalized hemodynamic resuscitation, assessing individual hemodynamic phenotype. And so there's a clear and audible algorithm with standardized training, and the hierarchical composite outcome with patient-centered and comprehensive outcomes. Limitations of the study includes a non-blinded study. Neither the patients nor the doctors were blinded. And variability is there in the clinical decision-making, especially regarding discontinuation of vasopressors, extubation, intubation, and initiation of renal replacement therapies. And heterogeneity between the centers, since it is done in like 86 ICUs in 19 countries, there is definitely heterogeneity between the centers. And the variability in the measurement of capillary fill time and non-validated physiological thresholds. Author's conclusion, among patients with early septic shock, a personalized hemodynamic resuscitation protocol targeting CRT was superior to usual care for outcome of mortality, duration of vital support, and length of hospital stay at day 28, primarily due to a shorter duration of organ support. And the clinical implication, structured CRT-guided personalization can shift organ support trajectories without excess fluids. Coming to the critical appraisal, the study validity. Was the purpose of the study convened plainly and rationally? Yes. Were the objectives of the study clearly stated? Yes. Was the study design stated and adequately described? Yes. Methodology, was the trial protocol and statistical analysis plan published before conclusion of enrollment? Yes. Was there any blinding? No. Was any funder involved in the methodology process? No. Was there a control population or a comparison group identical in all aspects? Yes. Were the baseline characters similar? Yes. Possible bias? Yes. And the results? Sample size estimation and power calculation mentioned? Yes. Are the basic data adequately described? Yes. Outcome measures properly defined? Yes. Were confidence intervals reported? Yes. Generalizability? Was study limitation discussed? Yes. Are study results applicable to local population? So that's the point of discussion today. And should it change practice? In my opinion, the study along with Andromeda shock support the capillary refill time as a useful resuscitation target in sepsis. But in practice, however, a multi-modal approach, combining CRT with lactic clearance, mean arterial pressure, urine output, and bedside assessment will be favorable. Anyway, further studies are needed to determine whether benefits come from capillary filter normalization alone or the entire protocol, or it's just an eagle's eye effect. Thank you.
Thank you, Dr. Ritu. The floor is now open for discussion, and I invite our expert, Professor Rakesh Garg, and our guides, Dr. Raghav Gupta. Sir, I missed introducing you, and my apologies. And sir is a assistant professor in the Department of Anesthesia and Critical Care, AIMS Delhi. And I invite Dr. Tanmay also, who has been the ex-chairman of ISCCM Lucknow and additional professor in SGPGIMS Lucknow. So I invite you all for your expert opinions, and over to Professor Rakesh Garg.
So may I request Dr. Raghav to just comment something?
Sir, may I comment one thing?
Yeah, Dr. Tanmay, please.
Yeah. We are agreeing that it is a huge trial with a huge publication, 86 ICU involved, 19 countries involved, and a huge JAMA publication. But what actually the study is targeting? It is micro hemodynamic, yes. But ultimately, what wins? Micro versus macro. We are still not well versed with CRT. I think it is a bit time consuming and a more bedside presence for residents to be needed. What do you think? Is it a good practice or practice changing to the mentors? Prashant?
Sir,
Or
if it was, sir, practice changing, what I feel this trial got published this year, and we could have measured CRT time in each and every patient in sepsis, but that doesn't look like a practice changing method. Still, we are following the standard protocols to see the fluid responsiveness, static versus dynamic fluid responsive tests. We are looking. Lactates still are the cornerstone. And yes, in resource poor settings, maybe we are in the tier 2 cities or metro cities, maybe where lactates are not available, where there we can consider CRP normalization protocols to see the endpoints of the resuscitation. So that is my take on this. Another thing was they just, sir, saw the 6-hour resuscitation bundle, and they have commented about the 28-day mortality. So again, whether this 6 hours, just 6 hours of optimization, whether it is concluding into the 28-day mortality, that was one question that which Dr. Ritu already addressed in the discussion. So as we concluded in the clinical impact slide, that it will be a multimodal approach. Yes, we will be looking at the CRT, but it will not be the only endpoint resuscitation marker in our routine practice.
I think within few years there must be some non-invasive pulse ox like things for CRT. Otherwise, it is difficult. Anna, what do you think, sir? It is difficult, na CRT for 3 hours, first hour, 3 hours, 6 hours, 12 hours. I think it is.
There are
resource
few
poor
things
countries.
regarding this trial. If you look at
Yeah.
that, first thing is that suppose that why they need this trial to be concluded. First thing, second thing that if you will see that what is there is one table So you have already showed Dr. Ritu. So in that, only significant is that what exactly? Length of hospital stay, vasopressor, whether you are minimizing it or not. If you will see the mortality was totally non-significant. Important thing is that this is Andromeda SOP 2 trial. So why they need this trial? Because Andromeda SOP trial, it already being published earlier. So why they need SOC 2 trial? First thing. Second thing, that there are many post hoc analysis about that Andromeda SOC 2 trial. Few systematic review and meta-analysis also published based on that. If you will go through that, you will feel that yes, CRT is good predictor in comparison to lactate. Why? Because if you will see in the low resource setting, this is a bedside approach, easily you can apply that. So most of the trial after the this article published post hoc analysis, all these are were in the favor of capillary refill time. So very easy and non-invasive tool. Regarding that, one thing I would like to ask to you, why they need this Andromeda SOC 2 trial? Because already Andromeda SOC trial was published. Can you tell me? Already you have shown that.
No, that is JP, that is clear. They are now going into the micro hemodynamic. Getting my point?
Yes.
Better than targeting a 65 map, a lactate with less than 18. They are more into clinical, more into microcirculation. I think it will be the thing or background behind their thinking. But yes, though that ultimately in discussion or in last session you said that there must be some close relation with
Though
macro plus micro. That
no,
means a multi-layered, maybe
no,
individualized.
Sir,
CRT is
may I
basically
answer,
based
Dr.
on that
Jay,
Yeah,
your
whether
yeah, yeah.
question?
Please, please, please,
so
please,
if you will
please.
see that why, because in Andromeda
Lactate.
SOC trial there are many strength and limitation. Based on
Yes.
that, the first trial changed the thinking. But if you
Yes.
will see this trial, that Andromeda SOC trial that earlier published, it not settle the question. So what if you will go through their strength and limitation, you will find that mortality significant mortality signal was not statistically significant. If you will go through the heterogeneity in CRT measurement, all this
Yes.
came in picture, early versus late resuscitation. So that is why they concepted and they just made this trial in a 90 country multi-center and with larger sample size.
Yes, sir. And just to add one thing, in the Andromeda Shock 1 trial, they found that lactates were falsely elevated in certain cases, like non-septic patient with liver failure and other causes of lactic acidosis. So they
Yeah,
wanted to
exactly. That's
address
why I'm
that
saying
also.
that
Yeah,
lactate is not a purely a hypoperfusion marker.
correct. Yes, sir.
Anything from your side, Rakesh
Yeah,
Galpur?
perfect. I think it's was a good discussion. If we see the overall the study, the methodology appears to be very strong. So this is one of the strong pillar of this study. They have been very precise and they have been very objective in assessing the parameters they have used. So I will label this study as methodologically very strong. The second strength for this study is, and we need to understand those who are listening to us in this journal club, majority of time when studies are published, we will try to look for a soft outcome or a surrogate outcome. But they have also reported a composite outcome, which you mentioned in one of your slide. So we have to treat patient as a whole. So we cannot say that if the vasopressor support has decreased from 5 days to 4 days, or the some parameter has decreased, but what about overall outcome? So the composite outcome was indicative of the beneficial effect of CRT. So this is important aspect. But simultaneously, if you break up the composite outcome, which they have mentioned, it was predominantly loaded by the vital organ support. You mentioned in your slides that the vital support free days was a little different. So this is again important when we talk about sepsis management, that though the mortality at 28 days was comparable into the groups, but the requirement of vital organ support was lesser in the CRT group. And we know that when the vital organ support is increased by duration, the chronicity of the disease becomes little more. And if you see the study, there were good number of patients who were diabetic. If you probably they have not mentioned subgroup analysis, but India is a diabetic country. And when we say diabetic country now, India is having almost like an epidemic of diabetes. And this is almost, you can say 23%, 22% of diabetes, right? So
Yeah.
when we say diabetes, the chances of infection becoming florid is more higher. And these patients will have hemodynamic instability also. So if you are decreasing the vital support, this means the organ functions will be preserved. So this is another big strength that this study is giving to us. So we can take it further on. But if we try to translate into an Indian population, I think this is question for the presenters also. They have tried to include patients who are having recent sepsis. If I remember, they mentioned somewhere within 4 hours. But if you see the Indian population, the tertiary care hospitals are good. So I would say that if somebody is working at a tertiary care hospital, I think this care will be given immediately. But what about the peripheral ICUs, where usually these patients will be shifted to those ICUs after 24 hours, 48 hours, when the organ damage have already initiated. So how will we translate this study into a peripheral ICU, or because the late transfer in the peripheral areas of India, wherein they get tertiary care utility because they have used certain equipments here. So that becomes a limitation. So how we will extrapolate it, I think that's, we can say, limitations in a low resource setting. But definitely, as Dr. Jayaprakash and Dr. Tanmay also mentioned, this study is primarily focused on what we have been doing for very long. If you see the pulse pressure changes or the hemodynamic changes, we have been doing for decades. But then we have shifted to more invasive monitoring, and then we're proceeding further. And now we are going for more of a ultrasound-based studies and cardiac output-based studies managing it. So I think somewhere needs to be balanced. I think this is a perfect, very good study for a tertiary care center. But how we will extrapolate for a peripheral ICU, or maybe a limited resources, or a patient with late presentation. So that is what we need to think and extrapolate it. Probably we need more study. But I am absolutely mesmerized by this study. And another important thing, I'm sure that this was a multicentric study and they would have taken care of, was the lack of blinding. So lack of blinding sometimes becomes a little issue when we are managing those patients, because sepsis do include clinical observation. So maybe that risk of bias may be there.
With the permission of Kalavati ma'am and Jayaprakash, can I add just one or two things about this? And Rakesh sir.
Yes, sir. Yes, sir.
Yeah.
Yeah, thank you. I think first of all, it's a very good presentation by the presenter, and she presented very well about the study. And many of the things has already been discussed by Dr. Jayaprakash, and I think Rakesh sir has also pointed very important things about it. Considering the fact that no blinding was there, I think straight away a performance or a co-intervention bias was there in this, because you can't know that how the clinician behavior would be. First, second important point, there are various other factors also based on that CRT, whether because these values may be influenced by many things, like your age of the patient, like your vasopressor dose. I think she talked about that also. So this could be considered as one of the important inter-observer variability among in that line, I think, because there are various factors which influence your CRT measurement as well. And I think the important aspect is another thing is that mortality endpoint. I think again there will be many more factors in septic shock, like your source control and antibiotics and comorbidities. All these factors may lead to that mortality or affect the mortality endpoint as well. So your microcirculatory benefit may not translate directly into the survival benefit. And Rakesh sir talked about it, that these findings cannot be again extrapolated to our Indian population,
There
very
was
right.
no
Then let septic shock patient
non-significant.
and
It was mortality. If you will see that it was
yeah,
not. That's why Andromeda shock trial came first. It came to change the conversation.
yes,
But
yes,
if you will see that shock 2 trial, it needed to change the practice. That's
yes,
why
yes.
they published with all the strength and limitation,
This is what
all those
I'm just
things.
telling. Yeah, yeah.
So I feel that besides that, we should start our second session, and the presenter is Dr. Marina. So Dr. Marina is doing DNB critical care medicine in Manipal Hospital, Whitefield, Bangalore, and her mentor is Dr. Anjana. So welcome you both of you. See, Dr. Anjana is senior consultant in critical care medicine, Manipal Hospital, Whitefield. So over to you, Dr. Marina.
Thank you so much, Dr. Jay. So there has been always a dilemma in the fluid resuscitation in any of the conditions in ICU. And we will be presenting waterfall trial. Over to Dr. Marina, please.
Thank you, ma'am. Very good evening to all. First of all, I would like to thank Dr. Anjana ma'am and Dr. Shivangi ma'am for
Make
the
it full
conference.
screen,
You're not
Dr.
audible,
Marina.
Dr. Marina.
Your voice is, yeah.
Yeah.
Yeah, Dr. Marina, make it full screen.
Yes, sir.
Full
Yeah.
screen and check your audio also.
Am I audible now, ma'am?
No, it was full screen earlier.
It was
Now
full
it
screen
is.
only.
You can,
Yeah.
Yeah. Please.
Am I audible now?
yes,
Yes.
go on. Yes.
Thank you. I would like to thank the ISCCM Journal Club coordinators and mentors for this opportunity. I would like to thank Shivangi ma'am and Anjana ma'am for constant guidance and support. So I'll be talking on the waterfall trial, the early weight-based aggressive versus non-aggressive goal-directed fluid resuscitation in the early phase of acute pancreatitis, an open-label, multi-center, randomized controlled trial. The trial was published in New England Journal of Medicine in the month of September 2022. So the acute pancreatitis has a global incidence of 33.74 patients per 1 lakh person years. And among this, 35% of the patients develop moderately severe or severe pancreatitis. And almost 1.6 deaths happens among these patients. So the pathophysiology associated with acute pancreatitis is the severe inflammation and associated third spacing of fluid. So observational studies have indicated that hemoconcentration was associated with pancreatic necrosis and thus progression to severe disease and mortality. So fluid resuscitation has been the cornerstone of treatment in patients with acute pancreatitis. But which fluid to be given and how much fluid to be given and when to stop the fluid resuscitation? Even though randomized clinical trials and meta-analysis has been conducted, this is still ongoing confusions in this area. So on this background, waterfall trial was conducted. They had a clinical question in adults with acute pancreatitis. Does aggressive fluid resuscitation compared to moderate resuscitation result in a reduction in the development of moderately severe or severe pancreatitis? So this was a multi-center, open-label, parallel group, randomized controlled superiority trial done in 18 centers across 4 countries, but majority of the patients, that is 85% of the patients, were enrolled from Spain. The trial was conducted from May 2020 to September 2021. Randomization was done in a 1:1 ratio using computer-based central randomization. The random assignment sequence was concealed from the trial tree, but the patients and the investigators were aware of the assignment. Stratification was done according to trial center, presence or absence of SIRS, and presence or absence of baseline hypovolemia. So the inclusion criteria were adult patients who presented with acute pancreatitis within 24 hours of onset of pain and the patients had to be randomized within 8 hours of confirmation of pancreatitis. They had a long list of exclusion criteria. They excluded patients who presented with shock or respiratory failure at recruitment. That is, the patient who presented with moderately severe or severe disease were excluded. Then the patients who had uncontrolled arterial hypertension, NYHA class 2 heart failure or worse, decompensated cirrhosis, chronic kidney failure, clinical signs or symptoms of volume overload at recruitment, electrolyte imbalances at time of recruitment. All these patients were excluded. That means the majority of the patients who will come to ICU for the treatment, all those category of patients were excluded. They also excluded patients who had severe comorbidity associated with an estimated life expectancy less than 1 year, and patients who had confirmed chronic pancreatitis. Coming to trial procedures, so after the randomization, the patients were randomized to 2 arms, that is aggressive fluid resuscitation and moderate fluid resuscitation. Patients in aggressive fluid resuscitation group received a bolus of 20 ml per kg over the first 2 hours, irrespective of their volume status, followed by an infusion rate of 3 ml per kg per hour. That is, standard 70 kg adult would have received a bolus of almost 1.5 liters and then infusion around 200 ml per hour.
Dr.
In
Medina,
the moderate fluid
you close your video screen
resuscitation
so that
arm,
voice will not break up. Now you present.
Okay, sir. Sure, sir. Yes, sir. The patients who were in the moderate fluid resuscitation arm, those patients who had baseline hypovolemia, only those patients received a bolus of 10 ml per kg. And the fluid infusion rate was set at 1.5 ml per kg per hour. That is, adult with 70 kg would have received a bolus of 700 ml if baseline hypovolemia was present, and an infusion rate of almost 100 ml per hour. So after the initiation of treatment, a safety checkpoint, that is physical assessment of fluid overload, was done at 3 hours. If the signs or symptoms of fluid overload was present, the fluid infusion was decreased or stopped. Then a physical as well as biochemical assessment was done at 12 hours, 24 hours, 48 hours, and 72 hours. So in both the groups, if the patient was found to be in hypovolemia, the patients in the aggressive fluid resuscitation group, if the patient was found to be in hypovolemia, a repeated bolus of 20 ml per kg was given, and then the infusion was continued at 3 ml per kg per hour. And additional boluses also could be given to maintain a urine output of at least 0.5 ml per kg per hour and systolic blood pressure of 90 millimeter mercury. If the patient was found to be in normovolemia, the infusion rate was continued at 1.5 ml per kg per hour. That is 50% reduction was there. If there was suspicion of fluid overload, the infusion was either decreased or stopped. The minimum mandated hour for infusion in the aggressive fluid resuscitation group was 48 hours. Oral feeding was allowed at more than 12 hours if the PAN-PROMIS scale score was less than 5. And if the oral feed was stopped for more than 8 hours, then the fluid infusion was stopped. In the moderate fluid resuscitation arm, at each checkpoint, if the patient was found to be in hypovolemia, boluses of 10 ml per kg was given and infusion was continued at 1.5 ml per kg per hour. If the patient was found to be in normovolemia, infusion was still continued at 1.5 ml per kg per hour. And if the patient was found to be in fluid overload, infusion was decreased or stopped. The minimum mandated hours for fluid infusion in the moderate resuscitation group was 20 hours. Oral feeding was allowed at more than 12 hours if the PAN-PROMIS scale score was less than 5. And if the feeding was tolerated for more than 8 hours, the infusion was stopped. So they had given clear-cut definitions for hypovolemia. So they had defined hypovolemia by presence of at least one criteria, that is baseline creatinine of more than 1.1 milligram per deciliter or BUN more than 20 milligram per deciliter, hematocrit of more than 43%, increase in creatinine and or BUN and or urea from the previous value, urine output of less than 0.75 ml per kg per hour, systolic blood pressure less than 90 millimeter mercury without other explanation than hypovolemia, or a presence of signs and or symptoms of dehydration. Fluid overload was defined by the presence of at least two of the following three criteria. That is, at least symptoms, signs, or hemodynamic or imaging evidence of fluid overload. The presence of only one criteria was called as suspicion of fluid overload. Coming to outcome, the primary outcome was development of moderately severe or severe acute pancreatitis during the hospitalization. The secondary outcomes considered were development of organ failure, local complications, duration of hospital stay, ICU admission, number of days in ICU, use of nutritional support or invasive treatment, presence of systemic inflammatory response syndrome at each checkpoint, and persistent SIRS, that is lasting more than 48 hours, C-reactive protein levels in blood at 48 hours and 72 hours, death, and a composite outcome was considered, which included death, persistent organ failure, or infected necrotizing pancreatitis, and symptoms as measured with the use of PAN-PROMIS scale at admission and at each checkpoint. The safety outcome considered was fluid overload. So, as I mentioned already, the presence of two criteria among the three, that is either physical signs, symptoms, or the imaging evidence of fluid overload. And they had graded the fluid overload to mild, moderate, and severe. Coming to sample size, so the anticipated incidence of moderately severe or severe acute pancreatitis was considered to be 35%. This was based on a Spanish multicenter cohort study. With 80% power, detected a between group difference of 10% and a two-sided alpha of 0.05, a sample size of 744 was calculated. They had planned interim analysis, that is after 1/3 and 2/3 of the patient's enrollment. They had set three prior stopping rules. That is, first one was between group difference in the primary outcome with a two-sided p-value of 0.0015 at the first interim analysis or of less than 0.012 at the second interim analysis. Second stopping rule was clear evidence of harm in one trial group over the other, that is safety concern. And third stopping rule was a slow recruitment rate. The trial was overlooked by Data and Safety Monitoring Board, comprised of clinical pharmacologist, gastroenterologist, and a cardiologist. So the data was analyzed based on intention to treat analysis. The data, the categorical variables were reported as counts and percentages, and continuous variables were reported as means with standard deviation or medians with interquartile ranges. Differences in continuous variables were compared with the use of student t-test or Mann-Whitney test. Categorical outcomes were compared with use of a chi-square test. Multiple imputation technique was used for variables with missing data. Cochrane-Mendel-Hensel method was used to correct for randomization stratification factors. Pre-specified subgroup analysis was done for the efficacy and safety outcome. Analysis was performed with the use of SPSS software, SAS software, and R software. Coming to the results, the trial was terminated at the first interim analysis because of the safety concern. That is, they found a significant patients with fluid overload in the aggressive resuscitation group. So 249 patients were randomized before the first interim analysis. 122 patients in the aggressive resuscitation group and 127 patients in the moderate resuscitation group. The baseline characteristics of the patients were similar in both the groups. Coming to volume administration at different checkpoints. So the first 12 hours, there was a difference in the fluid administered to both groups. That is, the aggressive fluid resuscitation arm received a total of 3.4 liters, whereas the moderate resuscitation group received 1.5 liters. By the end of 48 hours, there was a cumulative difference of approximately 2.5 liters between both the groups. But here I would like to highlight the point that even in the moderate fluid resuscitation group, they had received almost 5.5 liters at the end of 48 hours. That is quite high for a moderate resuscitation. So coming to efficacy outcomes, here we can see that the occurrence of moderately severe or severe pancreatitis was high in the aggressive fluid resuscitation group compared to moderate resuscitation group. but this didn't reach a clinical statistical significance, maybe because the study was underpowered. The study was stopped at the first interim analysis, and hence study was underpowered to detect the primary outcome. Even the necrotizing pancreatitis, the incidence is more in patients who received aggressive resuscitation compared to the moderate fluid resuscitation. There was not much difference between the groups for the other outcomes, including local complications, SIRS, persistent SIRS, and other requirement of the invasive treatment, nutritional support, length of stay, or other organ failure. Now coming to safety outcome. So the patients who received aggressive resuscitation, they had a higher number of patients developed fluid overload compared to patients who received moderate resuscitation. The adjusted relative risk was 2.85 with a 95% confidence interval of 1.36 to 5.94. So this signifies that the patients who receives aggressive resuscitation, they are at higher risk of fluid overload. Subgroup analysis was done between the groups based on the presence or absence of hypovolemia and presence or absence of baseline SIRS response, but that did not yield any findings differed from the overall analysis. They also planned to do a subgroup analysis for persistent SIRS, but it was not performed because there was less number of patients in the subgroups. Now coming to discussion, WATERFALL trial taught us that aggressive fluid resuscitation increased the risk of fluid overload, and this results in higher intensity of symptoms, longer duration of hospital stay, and higher incidence of necrotizing pancreatitis. But this was done in a less sick patients. That is, I would say, patients with mild acute pancreatitis. Maybe these patients would have been admitted in ward also. What about the patients who are admitted to the critical care? Those who have severe symptoms, or those who have other comorbidities which expose them to higher risk. So earlier studies have been done in this category of patients with severe acute pancreatitis. So, but they have yielded different. The results were a bit confusing. That is, the studies conducted by Mao et al. In 2010 and 2009. They found that moderate resuscitation is favorable. But one study done by Boxbaum in 2017, they found that this study was done in mild acute pancreatitis, and they found that aggressive resuscitation results in earlier symptom resolution. But the meta-analysis concluded that moderate resuscitation is favorable in patients with acute pancreatitis. Coming to strength of the WATERFALL trial, this was a randomized multicentral trial. There is no loss to follow-up. The data was analyzed with intention to treat principle, relatively balanced baseline characteristics of the patients enrolled. There was clear protocol for fluid administration and pre-specified definitions for outcome variables. And there was a clear focus on safety outcomes. The limitations of the study are the trial was terminated early. So the primary outcome assessment, it's underpowered. This is an open label trial, and it could have introduced bias. The trial have excluded patients at higher risk of volume overload. That is, patients without significant comorbidities were assessed. And the cumulative volume of fluids was high, even in moderate resuscitation group at the end of 48 hours. The mandated minimum hours of IV fluids in both the groups. So in the real world practice, we tend to initiate the oral feeding as soon as possible. That is, as soon as the patient tolerates, and we tend to de-resuscitate patient. That is, tend to reduce the IV fluids after that. So they had given a minimum mandated hours of 48 hours for the aggressive group and 20 hours for the moderate group. So this does not reflect the real world practice. And majority of patients were enrolled from a single country, that is 85% from Spain. So this limits the external validity of the study. So the authors concluded that the use of aggressive resuscitation as compared to fluid resuscitation led to a higher risk of volume overload and did not show hypothesized benefits in the disease-specific outcome for the treatment of acute pancreatitis. Coming to critical appraisal, is the study question relevant? Yes. Fluid resuscitation is crucial in acute pancreatitis to combat hypovolemia, improve microcirculation, and to prevent necrosis. So hence, the fluid resuscitation in acute pancreatitis is relevant. Does the study add anything new? Yes. They showed that early aggressive fluid resuscitation did not show benefits and can be harmful. What type of research question is being asked? The population included was adult patients with acute pancreatitis. The intervention was early aggressive fluid resuscitation, and control group was moderate fluid resuscitation. The outcome, use of aggressive fluid resuscitation as compared with moderate fluid resuscitation led to a higher risk of volume overload and did not show the hypothesized benefits in disease-specific outcomes. Was the study design appropriate for the research question? Yes. Did the study methods address the potential source of bias? No. Outcome assessor could have been blinded. Was the study performed according to the original protocol? Yes. Were the statistical analysis performed correctly? Yes. Do the data justify the conclusions? Yes. Are there any conflicts of interest? No. So I would like to conclude with saying that moderate fluid resuscitation is safer than aggressive fluid resuscitation, and frequent reassessment with multimodal gadgets, that is the physical signs and symptoms, as well as the ultrasound assessment, is preferable. And fluid boluses, that is 10 ml per kg, are recommended for patients who have hypovolemia. So these are the International Association of Pancreatology revised guidelines published in 2025. They recommend a moderate fluid infusion rate of 1.5 ml per kg per hour. And fluid bolus is recommended only if patient has hypovolemia or hypotension at present. And they state that additional fluids may be given depending on hematocrit and clinical signs of hypovolemia. So they say that the clinical signs and laboratory parameters should be considered when assessing the fluid status. So the targets given by them are map of 65 to 85 millimeter of mercury, urine output of at least 0.5 ml per kg per hour, one less than 20 milligram per deciliter, or blood urea less than 40 milligram per deciliter, and a hematocrit of less than 44%. Thank you.
Thank you, Dr. Marina. The floor is now open for discussion, and I invite our expert and our guides to lead the discussion.
Dr. Anjana, do you want to give your clinical interpretation based on this trial?
Yeah. So I think it was a good trial, multi-center, randomized control. Only thing was the blinding was not there. So there could have been some selection bias and performance bias. But problem was that they had a long exclusion criteria. So they excluded the severe or moderately severe pancreatitis, which are the patients which we see in ICU basically. They took the patients who had a milder disease or a milder pancreatitis or mild pancreatitis as per the Atlanta classification. So whether we can generalize it to our ICU patients, not sure. But if you see the in the primary outcome or secondary outcomes, the trend has been it's showing favorable towards a moderate fluid resuscitation only. It did not reach the statistical significance because they stopped the trial because of the safety concerns that there were the fluid overload. So it would have shown a favorable outcome for moderate resuscitation probably, but definitely now I don't think we give the fluids blindly for leave alone the pancreatitis for any of the conditions. We have so many gadgets to assess the fluid. It's not only dependent on per kg or a number. We have to combine it with the clinical, laboratory, and radiological, of course, the ultrasound for the fluid resuscitation. That would be the other limitation was that most of the patients were excluded, like the with the chronic renal failure, heart failure. They're all the comorbidities. So these are the type of patients we see in ICU, right? So they were all excluded out. So they were lesser sick. I mean, the patients which it took, they were less sick. But still, I think we get some information from the study that definitely aggressive, it has shown in other conditions also that aggressive fluid resuscitation is associated with a poorer outcomes in any patient in the ICU now. That would be my conclusion.
Actually, in earlier even guideline also, they promoted early aggressive IV fluid resuscitation. So that is based on especially in acute pancreatitis. And they earlier believed that if you will give more fluids early would then it prevents necrosis and organ failure. But this, after this waterfall trial, what exactly they show, it is not going to improve the pancreatitis severity, and instead of causing severe significant fluid overload. So yes, methodology is quite good in this trial. So we are coming to the time on. So I would like to, Dr. Rakesh Garg, sir, do you want to say thing on this one?
If you just give me, I'll just speak for 2-3 minutes, Dr. Jayaprakash.
Yes, sir.
I think this is a good trial, and the concern raised for blinding is acceptable. But we could accept that limitation because they have used very objective parameters of fluid resuscitation, at least for the first 3 hours. So I think that limitation may be acceptable, though the outcome assessors or again objectively measured it, though they have not put it how they did, but yes, it appears to be okay. The second aspect which they have not discussed in discussion, this will be for fellows and trainees who are listening to us. When we talk about acute pancreatitis, what is exactly the pathophysiology? Why this moderate fluid resuscitation was of lesser harm? They have not shown any benefit because of the premature stoppage of the trial.
Closure of the study.
So there are 3 things that needs to be considered, which Dr. Jayaprakash was touching. One, it is an intense inflammatory state leading to glycocalyx damage and capillary leakage. So whenever there is a capillary leakage and glycocalyx damage, there will be a fluid overload. That's for acceptable because it's an intense inflammatory state. So if you give a fluid bolus of say 20 ml, 30 ml per kg as a bolus, which is in the aggressive, it definitely will have leaking capillaries and it will lead into the respiratory system or other organ system and it will harm the patient. So this is what they have looked for. But why we give fluids? Because acute pancreatitis also leads to microthrombus. So we have to flush it. So we have to give fluid bolus. So I think based on this, they have not discussed why this harm has happened, not the benefit, because the harm will be because of leaky capillaries, but benefit, prevention of microthrombosis, which could lead to further microorgan ischemia, probably will be benefiting by giving more fluids and making them flushed, capillaries flushed. We cannot give anticoagulants for these patients because they are coagulopathy also. So that's why a balance of fluid is important. That's why people are moving towards the goal-directed therapy. And I'm sure that this will be helpful. And as Dr. Jayaprakash mentioned, that we have to give something goal-directed therapy for these patients. And trainees should also look for 2 things, how the endothelial are damaged in acute pancreatitis, one, and people should also learn, understand the glycocalyx model. The capillaries, the veins and arteries are not tubes. They have a good amount of glycocalyx which acts like a sponge and which is on the endothelium part. And they can be damaged by any acute inflammation. So when we talk of acute sepsis, acute pancreatitis, ARDS picture, we also need to consider that storage of fluid, which is there, needs to be balanced, which was called as goal-directed therapy. So this is in brief for trainees to read little more about fluid. If they can understand that model, they will be able to understand that how much fluid is the good fluid. Thank you. Dr. Jayaprakash.
So one thing, in this trial also, if you look at the moderate fluid resuscitation, they have given a lot of fluid in that I mean, around 5.5 liters in that. So I think whatever the purpose was there, that was solved even with in case of the moderate fluid resuscitation as well. Aggressive was too aggressive. That's what I could make out.
May I add something? So in the methodology, actually, there is the question of the Strawman methodology, where was it meant to fail, the overload state, whether it was meant to fail in the first place. But again, the rebuttal is that earlier guideline was at least 5 to 10 ml per kg per hour, whereas here the study, even in the aggressive cohort, it was only 3 ml, which still proved to be overloaded. And again, as you said, a significant group with all the comorbids like CKD and heart failure and liver failure, all of them were also excluded. So yeah, regarding methodology, that comes. So it is a pivotal study, definitely, and it challenges the established guideline where it was all go aggressive. And as we saw, it is again about frequent monitoring and frequent watching, as Rakesh Garg sir has told, and probably watchfulness for the overload, and as sir said regarding the glycocalyx and whether we are getting into the leaky capillary syndrome. So that is my take on that.
Just one more point from my side also.
Yes, sir.
So we also, for all the listeners who are listening to this journal club, that there is a lot of heterogeneity when we come to define what is aggressive, what is moderate, what is liberal, what is restrictive. So still we do not have any conclusive evidence that how do we actually define them. There are a lot of fluid management strategies and a lot of studies, but still every study differs. So for all the listeners, it is important to understand that clinical acumen also, when it comes to bedside practice, clinical acumen comes into picture apart from these studies and whatever they are concluding. So that everyone should remember that liberal, restrictive, all these are very different terms and different definitions are there all across the globe.
Yeah, I think to add to it, not the numbers. I think it's a clinical judgment, as well as we have so many tools now to assess actually how much fluid to be given, when to stop, when to de-resuscitate. I think we have a lot of things now. So
That's why the role of focus is quite important in that case. You have to look at that whether a stroke volume is good or not. So what is the status of the heart, myocardium, all things you have to take care of that one, and then you have to guide that.
Can I
So
can I can I
yeah,
ask
so I feel Rakesh sir, we
JP?
are on time. So shall we
Just one
wind
question.
up?
JP, hello. Am I audible?
Yeah, yes,
Hello.
you are audible.
Just Kalapati ma'am, one simple question. Can I actually get the acute pancreatitis within 24 hours in Indian setup in Indian ICU? Usually we get the severe acute pancreatitis one, and that is also not within 24 hours, I feel. And by the time you make ultrasound and everything done within, because they I think they have included only those patients who are less than 24 hours of acute pancreatitis diagnosis.
yeah,
And 24 hours, no?
yes,
24
within
hours.
24 hours after the onset of pain.
Yeah, it is difficult, don't you think, in our Indian setup? And secondly, what we are all discussing about,
we are getting that in Indian scenario. If you look at that, we are getting because patient will generally coming with the complaint of pain, and that is the reason we are getting the within 24 hours. And that's why this because previous guideline was saying that we have to give more fluid to prevent the necrosis, all those things. And but after this trial they said yes, volume overload, and now you can easily measure through your ultrasound sound that whether volume overload is there by clinical equipment. Yes, that is more important. One thing. Second thing is that besides that, how much fluid you are giving, some patient having, that is the role of personalized management. So if you will go in that one, then discussion will be broadened. So I feel that today for today's
again,
we should just
and again for the just taking the first presentation into account, can the capillary refill time based fluid strategy will work on here as well? And is just as Sarah said, the
no,
endothelium is
based
damaged.
on that, based on their trial, they compare lactate with the CRT, capillary refill time, and what
In acute
methodology
pancreatitis
they have
situation,
chosen that.
will it act the capillary refilling time? The capillary refill time based fluid strategy, say personalized fluid strategy you are saying, will it act here also in pancreatitis, acute pancreatitis, firstly? Secondly, their endothelium is damaged.
No,
Is there
no,
any
that's why they
biomarker for
wrote
fluid management?
they wrote not capillary refill time. If you will see that now, they wrote predefined also term PHR, predefined their resuscitation, what they already mentioned in their trial. Because they should be restrict on that one. Otherwise, the result, whatever it will be bias type result. Now then.
The capillary
Yes, sir, please.
So capillary refill time also, you cannot use it alone. Even if, I mean, in this trial, it's not used, but in any condition, you cannot use it alone. You have to use it with other tools, of course. It doesn't give the complete information.
Yeah.
And sometimes in Indian population, it's very hard to see the capillary refill. If you see the color, if
That
you
is
see
just
the
actually
this, that's very difficult.
that is non-invasive tool, good for the low resource setting. So
Yeah.
we should keep in that one in mind. Yeah, exactly. So I feel that Kalavati ma'am,
Yeah.
shall we end the session?
Yes, so that was a good discussion and a very dynamic discussion. And I thank all the expert academics who have given their time to contribute to this excellent topic and contributing for the critiquing. Any paper, we cannot take it on face value, and everything needs a critiquing. And there are dime a dozen papers being released day after day, but everything needs to be looked at critically. And this discussion has gone one more step in for the whole audience as well as for the trainees, teaching to look at everything with a critical eye. And yeah, we have indeed overshot the time, but it was a very valuable discussion. And I thank each of you for being here, for being present here, and contributing out of your vast experience and your knowledge. Thank you so much, and a good night to each of you.
Thank you, ma'am.
Thank you
Thank you,
all.
everyone, for the opportunity. It was my first time with everyone, but it has been excellent interactive session. Thank you.
Yes, it is very good,
Yes.
and we look forward to more
Oh, yeah.
academic discussions like this.
Thank you so much
Thank
to
you.
all.
Enjoyed a lot.
Thanks, a special thanks to
Long
Rakesh
live.
Garg boss.
Yes,
who
sir.
has
Thank you
given-
so much. Thank
always
you.
being our what you
Mentor.
brave man like that. So he's always giving us.
Thank you. Learning from each one of you, sir.
Yeah. Thank you, sir. Thank you so much. Sir.
Thank you. Long live ISCCM.
Thank you. Thank you, everyone.
Thank you. Thank you.
Thank you.
Thank you, Rakesh sir. Thank you, Dr. Tanmay. Thank you, Dr. Raghav.
Thank you.
Thank you.
Thank you.
Thank you so much.
Thank you. Thank
Good night.
you.
Good night.
Thank you, Dr. Anjana.
Thank you.
Thank you.
Thank you, Dr. Prashant.